Yes,
How
sir.
about Dr. Lakshmi?
We can see you, sir.
Now I can also see you after I turned off and then switched on again. So I got it.
Okay, sir. Yeah.
Dr. Lakshmi is okay, no? Others can see, no? I am not sure about others.
Lakshmi ma'am, can you see us? Nalli sir, can you see us? Dr. Nallikant.
We can see you, we can hear you.
Okay,
Yeah.
perfect.
Okay, ma'am.
Perfect.
Nallikant is mute is there, I think.
Now, fine. If the thing I am...
Go ahead, ma'am.
From my side is okay. Fine. Go ahead.
And this baby, after receiving second dose of surfactant, and even after second dose, baby pressure requirement was high, sir, in between 22 to 24, and FiO2 requirement was 35 to 40%. So baby was started on high frequency ventilation.
Wait. Hold on. What are your thoughts at this point of time? So suppose you have a baby like this, a baby depressed at birth, you brought and then you gave the first dose of surfactant, baby did not respond, you gave the second dose of surfactant, baby still did not respond, and you're thinking of escalating ventilator settings. So at this point, what are your thoughts? What is going wrong? Always, whenever you escalate treatment, before you do that, you should introspect, isn't it? You should ask yourself, what am I doing wrong or what is happening to the baby? Isn't it? So at this point, your introspection. Share your introspection.
So we'll think whether the underlying pathology, is it severity of the underlying pathology we should consider, sir. And any complication associated.
Like pathology, like?
Severe HMD.
Severe HMD, okay.
And other associated any infections.
Okay.
And any pulmonary hypoplasia in this child.
Okay.
And other complications associated with the treatment, whether baby developed any pneumothorax.
Okay, so now risk factors for each of this, can you analyze? Whenever this is how you introspect. First, what could be the problem? Then each problem, like what is the likelihood of having this? So first one you said severe RDS. What is the likelihood of this baby having RDS based on the data you have?
Because mother received steroids, sir, 2 doses of steroid,
okay.
2 days prior to the delivery, and the less than 28 weeker. Still there is a high risk for the severe HMD in this child, sir.
Anything else that will accentuate the risk in this case?
And difficult transition at birth can also cause.
Okay, so difficult transition also can be one of the. Fine. Anything else? So you feel the antenatal steroids time is adequate, reasonably okay, isn't it?
Yes.
May not be perfectly what you want, but reasonably okay, fine.
Yes, sir.
Anything else? Any maternal condition that would have some role?
Gestational diabetes, there was no history of gestational diabetes in this mother, sir.
There is no history of gestational diabetes. Okay.
And as such, in this mother, there was no history of maternal fever also.
Okay. So there is no history suggestivo chorioamnitis in the mother?
Yes, sir.
There is no history?
And no leaking? No, sir.
Okay, fine.
And even antenatal scan showed lighter was normal.
Okay, fine. Any scoring you are aware of? Prognosticating the outcome, because this is a from fetal report I could make out this may not be appropriate for gestational age baby.
Yes, sir.
Where do you place this baby at this point? In the yeah.
High risk.
No. In the weight category, where do you place this? AGA.
No, sir. SGA, sir. Less than 10 centile at birth, sir.
Is it IUGA baby?
Yes, sir.
Why do you say it's IUGA?
Because antenatal growth was also showed less than 3rd centile, sir. But we don't have the multiple antenatal scan reports. But this child, other like birth weight was only the less than 3rd centile. Other length and head circumference was just touching the 10th centile, sir.
Okay. So any other growth chart you would like to check with at this point in this baby?
Any clinical assessment, anything will guide us?
Sorry?
Anything physical examination or clinically can it guide us to define is IUD
Yeah.
baby or not? That's
Okay.
Clinical
Okay. So
scan scoring.
fine.
Scan
Fine.
scoring
Go
can
ahead.
tell about the fetal. Hello.
Yes. Go ahead. Go ahead.
Scan scoring can tell us about the fetal malnutrition in this child.
Again, video. Some problem.
You lost, sir.
No, it's okay. We can see you. Whoever is talking, we can see well.
Okay. Problem for my side. I'll again switch off and switch on and see. Last time that worked. Can you see me now?
Yes, sir. Yes, sir.
Yes. Okay. Go ahead. Go ahead. We are already almost half time, so we need to go to the baby. Yeah.
And then baby was continued on high frequency ventilation, sir.
Oh, okay.
And
Okay.
baby,
No. Wait. So you have decided to escalate your respiratory support.
respiratory.
So
Yes, sir.
why did you choose high frequency at this point?
Because baby is requiring high pressures, 22 to 24, and high FiO2 requirement. So to
What
prevent
would be
the
your initial starting pressure settings in high frequency in this baby?
this baby in high frequency, if baby based on the MAP requirement during the conventional ventilation, this baby was requiring around 12 MAP. So we'll start with the 14 MAP and delta P based on the adequate wiggle till the umbilicus, and frequency based on the CO2 and ventilation during the conventional, and FiO2 as per the requirement.
Okay. Then how did you make sure that the lung is well recruited after this?
We'll repeat the chest X-ray after 1 hour, sir, and we'll do the blood gas to look for the ventilation and oxygenation part after starting the high frequency ventilation.
So you were able to maintain on the same settings. You said your MAP of 14, and what is your delta P?
Delta P was 28, sir.
28, and other settings?
Frequency was 12.
12.
And FiO2 was initially 40%.
Okay. Do you have any blood gas just before converting?
No, sir. At present, sir.
You don't have the detail. Okay. You have, okay. Fine. Okay. So you converted. Continue.
And this baby required high frequency ventilation for 8 days, sir.
Okay.
And after that, baby was changed to conventional ventilation. And by day 12 of life, baby was extubated to CPAP.
Okay.
And after 4 days of CPAP, again baby had increased work of breathing and required intubation, sir.
Okay.
So on day 18 of life, baby got intubated and required ventilatory support for 2 days and then extubated to CPAP.
Any thoughts on what is all happening at this point? Why all this happened?
Because there was background, also there was a severe HMD, and also there was background sepsis in this child, sir.
Severe HMD. What is the temporal profile of HMD?
What is the natural course? Temporal and natural course.
And
What happens normally?
normally during initial 2 days, there will be increment in the severity of the disease.
Okay.
And over the next 4 to 5 days, usually it will get subsided, sir.
Okay. So when that doesn't happen, then do you want to suspect anything more?
And in this child, other than the respiratory, cardiac, we need to look at, sir. Is there any underlying cardiac?
What cardiac?
Abnormality, cardiac. And PDA, and is there any PPHN in this child?
So have we made sure that? Have you done that?
Yes, sir. This baby had severe hemodynamically significant PDA, sir.
When was it?
And baby was
What was the? Can you be more precise on that? Actually, when was the echo done, and what were the findings, and how did you interpret the findings as hemodynamically significant?
Exact detail I don't have,
Details.
sir, but on day 4 2D echo was done, sir.
Okay.
It showed a dilated LALV with the left to right shunt.
Okay.
And there was no comment regarding the ductal steel on descending aorta, sir.
Okay.
But
so
baby was that time started on paracetamol, sir.
Okay. What was the dose you are given? Paracetamol?
Loading dose of 25 mg per kg we have given, and 15 mg per kg every 8 hourly for 5 days we have given, sir.
Okay. And then the PDA closed.
Yes, sir. And then PDA closed.
Okay. We'll just deviate from here. Actually, PDA. What is the normal? What is the recommendation regarding PDA? Very controversial topic.
Sir,
You can, if you want, you can talk. Otherwise, we'll go on to next. I just want to hear your views. That's all.
so PDA, there are different
how did you make sure this PDA is hemodynamically significant? And in such a scenario, will your closure make any difference? That is the question. Evidence based. Okay.
Yes, sir. Because in this child we had the difficulty in managing this child respiratory wise. So we consider echo in that because of the PDA there was a flooding of the lungs and there was increased oxygen requirement in this child. And
you had pulmonary hemorrhage. Bleeding of lungs means pulmonary hemorrhage.
No, sir. Flooding.
Flooding. Okay. I heard bleeding. Okay. So did you? Okay. Go ahead.
And in this condition, baby is on significant respiratory support with cardio 2D echo suggestive of hemodynamically significant PDA. We will consider paracetamol in this child, sir.
Okay.
And baby is also required persistent respiratory support with high FiO2 requirement.
So did you for this thing consider any other drug other than paracetamol?
No, sir, in our unit we use paracetamol, sir.
Yeah, what are the other drugs which can possibly be given?
Indomethacin and ibuprofen.
Okay, do you want to talk anything about it?
Yes, sir, because there is indomethacin is not available here, sir, and even we are difficult in getting ibuprofen also.
Okay, fine. Go ahead.
And this baby, respiratory wise, on day 28, baby was on CPAP support, sir, and eventually baby was room air by 35 plus 3 weeks.
Okay.
And cardiovascular.
So what is the red flag that is striking you at this point?
So there is a risk of chronic lung disease in this child, sir, because at day 28 baby was on significant respiratory support.
How do you define this CLD of prematurity? Yes, classic definition. Do you want to clearly make sure how is the severity and all? So just define CLD. How do you define CLD?
So if any preterm requiring respiratory support at day 28 of life.
Okay.
And based on the requirement at 36 weeks of gestation, we can grade the CLD, sir.
Okay.
If baby on respiratory support at day 28 and if there is no oxygen requirement at 36 weeks of gestation, we'll classify them as mild.
Okay.
And if from 21 to 30%, we'll classify them as moderate. And anything more than 30, we'll classify them as severe.
What is the implication of this?
So it will implicate the long-term neurodevelopmental outcome and also long-term respiratory morbidity in this child.
What is the pathology you are scared of in CLD?
So decreased alveolarization and arrested alveolarization as per new BPD.
Okay. This is new BPD or old BPD?
This is new BPD.
New BPD. Okay. So you're worried about arrested alveolar development, isn't it?
Yes, sir.
Okay. So now can you just take us back to the growth of alveoli? How long it some numbers do you have? Like so many alveoli are present at this period of gestation, and then it becomes so many by this period of gestation, things like that? If you
Sir,
want
it
to
all
only-
depend on the stage of the lung development, sir.
Okay.
During embryonic and pseudoglandular, this at this stage, baby might be in early stages of the saccular development, sir,
Okay.
like 28 weeks, and just at this saccular stage, usually they will have the acinus in early development, sir, without much of alveolar.
Okay. So
So there will be no secondary alveolarization and no septa formation will be happen, sir, in the postnatal.
how many? I mean, what is the percentage of alveoli that develop by this 36 weeks and 40 weeks? Anything? Any values you are aware of? Or
No,
number
sir.
of alveoli and all? Okay, go ahead. Go ahead.
And then coming to the cardiovascular part, sir. So baby on day 2 of life had hypotension and required inotropic support for 2 days, sir. And baby also had
which inotrop did you use?
And dopamine and adrenaline was there, sir.
Okay, why did you choose these inotrops? If at all you chose, I mean, suppose you're choosing this, what is your justification?
So initially, because according to the targeted, according to the age, baby blood pressures were on the lower side, sir. So usually we start with the dopamine. So on dopamine, if baby is not maintaining,
what is the? Let us look at probably this again is a controversial topic. Various people have this. What is the problem with dopamine? When you use a drug, you should know the problems with that drug, isn't it? What is the problem?
Yes, sir.
With
It
dopamine?
can cause severe, in higher doses, it can cause vasoconstriction, and it can increases the PPHN, and also it can affect the vascularity to the gut.
You already said the left ventricle and left atrium are enlarged, isn't it? And there is left-right shunting. That's what your echo said,
yes,
isn't it? So if you use
that was on day 4.
If you use inotrope dopamine at that point, then what is going to be the problem? Okay, this
so it will
different time, huh?
Yes.
No, it's different time.
Yes, sir. Yes, sir. It is different time, sir. On day 2 we started dopamine. Day 4, 2D echo showed dysfunction.
Okay, fine. Go ahead. Some video is coming and going. I don't know, something problem with my side or whatever is the other thing. You are able to hear me continuously, no? That's all what matters.
Yes, sir.
We can't see you, sir. We can hear you.
I am also not able to see myself, and in between your video is coming and then it's going. I don't know what to do about it.
Nalli, sir, can you see us?
Let me switch off and switch on again. I think every time it has to be done, it automatically switches off after. Now you can see me?
Yes, sir.
Okay. So go ahead. So
and this baby.
Go ahead.
So baby was treated for PDA, sir, and on the day 1, this baby subsequently we have done sepsis, and baby was started on antibiotics and antifungal prophylaxis, and initial septic.
Can you throw more light on that? When was the sepsis detected?
On day 3 of life, sir.
How did you detect sepsis in this baby?
In this baby had leukopenia and thrombocytopenia, sir, with high CRP.
Okay. So which of these you take as the most important sign? You said 3 signs: thrombocytopenia, leukopenia, high CRP. Leukopenia. Okay. Why you want to act on leukopenia, not on the other ones?
Because it is very important for the immunity of the child, and again.
Okay. So then, what did you do? So you upgraded antibiotics. So what was done at that point when sepsis was detected?
Yes, sir. We have upgraded the antibiotics, sir.
Okay.
And then
anything isolated? Any bug
No,
isolation?
sir. Nothing was isolated from the blood, sir.
Okay, fine. So he had fine. Go ahead.
And then baby was nutrition wise on day 1. Baby was started on minimal enteral nutrition.
What is
And,
MEN?
central
What
line-
is minimal nutrition?
Minimal enteral nutrition is to prime the gut. It is 15 to 20 ml per kg per day. Will start on day 1, sir.
What do you want to start with?
Mother's milk, sir.
Mother's. So you started with mother's milk. Now, what
Yes,
is
sir.
okay? Then go ahead.
Then we have placed umbilical lines in this child, and we also started on total parenteral nutrition on day 1.
What? How did you
So
start
baby was-
again?
We start with the aminobin of 3 grams and lipid 2 grams, sir.
Okay.
And we'll gradually increase and to 4.5 and 4 gram of lipid.
Okay, fine.
Protein.
What is the target
And
calories and proteins by the for this baby at this point?
at the initial first day, around 60 to 80 kilocalories per day, sir.
Hmm.
And protein, as per recommendation, from anywhere between 2.5 to 3.5 grams,
Okay.
and lipid 2 to 3 grams.
No, I'm not asking about lipid. Why do you want to give lipid? What is so essential about lipid?
Because during whatever supplementation we are giving, baby deprived of the
You should
essential.
know how to take cues from the questions. I asked what is so essential about lipids in this baby.
Essential.
Because there is lack of essential lipids in this, essential fatty acids in this child, in this
Okay.
extreme freedom. So we'll supplement with the lipids, and it will improve the calorie dense.
Okay. Okay. You want to talk? Okay, fine. So, how much? What is the target? You say how fast you want to increase your calorie targets?
Sir, per day we increase 20 kilocalories, sir. By day 5, day 6, we'll reach the 110 to 120 kilocalories.
Okay. What is EUGR?
EUGR, it is based on the weight growth of the child. Either at 36 weeks of various studies, they have used different criteria. Sir, at 36 weeks of gestation, if the weight of the child is less than 10th centile, then we'll classify them as extrauterine growth retarded babies.
Okay, growth restriction, not retarded. Okay, fine.
Growth
So, what is actually important in EUGR? I mean, the way it's not some new concept regarding is it the weight or something else that determines the prognosis of EUGR babies?
Rate of growth and
Okay. If you want a value at a point of time, something other than weight, any better parameter. I'm not saying weight is not a weight is the most practical parameter in our clinical setting, but something may be more ideal, because what happens is when you give things, feeds, what is going to happen? Sometimes the fat content will go, fat level in the body will go up, isn't it, babies?
yes, sir, yes, sir.
So what is that is not going to have any importance for you as far as neurodermal outcome is concerned. So what is important?
Protein calorie ratio we should.
Okay, that is how you manage feeds. Protein calorie ratio should be maintained. I am asking something else. More than weight, what should be your target when you treat EUGR babies? Some new concept. If you want to answer, otherwise we can go on to next one.
We should maintain blood urea nitrogen levels within target.
What is lean body mass?
Lean body mass without the fat content of the
Okay.
child.
Do you want to know? I don't think you can know every time. Do you want to know the lean body mass of these EUGR babies?
Yes, sir.
Why? What is the importance?
Because if we supplement with the, if we don't supplement adequate protein, and if we supplement with the extra fat content, and that will not useful for the catabolism and anabolism for the baby.
That is why you don't give things like which we used to go give 10-15 years ago, like MCT oil and all.
MCT oil, yes.
Isn't it? So you don't want the
Yes.
weight to grow. You want actually the lean body mass to
Lean
go
body.
up and follow the uterine growth chart, isn't it?
Yes, sir.
So before we go on to that, just tell me some of the charts that you follow up at this point.
Yes, sir. We used for less than 32 weeks Fenton charts, sir.
Okay.
The reference charts.
What is the difference between the modified Fenton's and the old Fenton's chart?
Old Fenton, there was not sex specific, sir, and we were unable to plot in between gestation. So in this new 2013 Fenton, these are sex specific, and we can plot in between gestation also.
What is the criticism with Fenton's chart?
Sir,
what is the problem with Fenton's chart?
It will overdiagnose the EUGR babies, sir.
Okay. So what do you want to do? Any other? Okay. Tell any other charts you are aware of in the intrauterine period?
Intergrowth charts.
Okay.
These are the standard charts.
Okay. What is the difference between the two, Fenton's and Intergrowth 21?
Fenton, it is a reference chart, and these are descriptive. And Intergrowth, these are standard charts, and they have taken health status of the neonates into consideration, and they have plotted the both.
Okay. Anyway,
anthropometric.
let's not deviate from the what you're talking. So you started with MEN, isn't it? Now how fast should you be going up on feeds in this baby?
So in this child, sir, initial 48 hours we have given the minimal enteral nutrition.
Okay.
From day 3 onwards, we have
what is immunonutrition?
Sir?
Immunonutrition. Heard of the term?
No, sir.
Suppose you want to, you are forced to give anything other than MOM. MOM is mother's own milk, isn't it?
Yes, sir.
Then do you want, is there any concept? I'm not saying it's a verified concept of adding MOM to that. Suppose you want to give formula or formula or PDHM. You add mother's own milk little to that. The purpose is
probiotics.
What is rephonation? Rephonation of milk. Yeah, you are somewhere in the region when you said probiotics. You are somewhere in the region.
I'm not aware, sir.
Okay, fine. Go ahead. We'll discuss later. Yeah.
And from day 3 of life, this baby was started increasing on the feed volume, sir. And by day 8 of life, baby reached 100 cc, and baby was started on fortification.
Okay.
And by day 14 of life, and this baby reached the full feeds, that is 160 cc per kg. And we were continued on mother's milk, donor milk, and with the fortification.
Okay, so what is the percentage of mother's milk, and what is the percentage of donor milk, and what is the percentage of formula you have to use in this baby? You use formula?
In this baby we have... No, sir. We use donor milk.
Donor milk. You have plenty available. Some of the centers?
Yes, sir.
Yeah, okay, fine. Okay.
So in initial days, the mother milk was lesser. Major part was given the donor milk. And by second week of life, most of the time we used to get the mother milk.
Okay.
So exact ratio I don't know, but most of the time we have used mother milk.
Fine. No issue. I'm just fine. Go ahead. So this baby, now you are talking about the second week, baby was on full feeds, isn't it?
Yes, sir.
So what are the implications, positive and negative, of nutrition at this point with the baby's disease conditions? Baby, you said is a CLD of prematurity, isn't it?
Yes, sir.
Okay.
And nutrition, usually it will improve the long-term neurodevelopment, and it also helps in the lung maturity and other organ maturity, sir.
Okay. Go ahead. And
with adequate weight gain, so we can decreases the other comorbidities in this child.
So what was your target protein and calories at 2 weeks of age when you reach full feeds? You reached on day 10 or day 14? What day you reach full feeds?
Day 14, sir.
Day 14. So day 14, what was your target? What should be your target? Or what are you giving? Either you can say
Calories around 110 to 130, sir,
okay.
with protein of 3.5 to 4 grams.
Okay.
With calorie protein ratio in between 30 to 35 to 1, sir.
Okay. Okay. Now then suppose you achieve that. That's the minimum standard we want. So if you want achieve that, then how are you going to monitor growth after this?
So regularly we'll monitor the growth by plotting on every week we'll plot growth, sir, on the growth charts.
Okay, you plot on every day and every week, but then would you like to check every day weight?
Weight we check, sir. Every day weight we check.
Okay, fine. So how are you going? Now my question is, how do you assess the growth? Thereafter, how are you going to assess the growth of the baby? Understood? No? You understood the question, no?
Yes.
Right.
Yes, sir.
Yeah.
So based on the daily weight of the child and whether it is, and also other metabolic parameters also will take into consideration, sir.
Okay.
Whether baby is growing or not. So based on the electrolytes and based on the blood urea nitrogen levels, whether baby is getting adequate protein or not.
Mm-hmm. Suppose the baby is deficient in calories and proteins. Which one would you give prioritize, calories or proteins?
Proteins.
Why do you want to prioritize on proteins?
Because it will help in the maintenance of the catabolism of the baby. So, and it will decreases the energy expenditure.
Okay. On the other hand, you said about protein energy ratio, isn't it?
Yes, sir.
So what is the significance of that?
So it will improve the lean body mass of the baby.
Okay. Now suppose you give excess protein and then calorie is deficient, then what is going to happen? That is what I meant.
So excess protein in the body can
and calorie is deficient, isn't it? That's what I said.
Yes, sir.
So then how will this protein be used to create calories?
Yes, sir.
So when that happens, then what is the problem?
There will be decrease in the total lean body mass and
no. So how do you monitor that? I'll ask in another way. How do you monitor that? Any parameter you want to check which can tell you, okay, something is going up. Okay.
Monitor, sir.
Okay, great. You are on the point. You got that trend of questioning. No, okay, fine. Go ahead. We don't have time. 3:15 already. Yeah.
And currently, since last 1.5 weeks, sir, baby was started on formula feeds as and currently baby is on 180 cc per kg of full feeds, and baby is getting calories of 142 and protein of 3.7 with the vitamin D supplementation of 1095 international units with calorie protein ratio of 38:1, sir.
Okay.
And since last 3 days, baby is gaining weight adequately.
Anything you have missed in your presentation? If you have finished, have you finished? Any other aspect?
No, sir.
Because when you said you already reached 2 weeks, 3 weeks, and all, something I would do much early, which you want to do much early, which were not mentioned so far. Let's go on to not go on to now second week and all that. First week itself something.
Yeah, we have screened the intraventricular hemorrhage, and there was no intraventricular hemorrhage in this child, sir.
Okay. Are you more worried about intraventricular? Okay, because the baby was depressed, you wanted to screen. What is your screening protocol? What should be your screening protocol? So
we'll usually, based on the baby's hemodynamical stability and the gestation age, sir,
Okay.
For less than 28 weeks with this kind of picture, we screen on day 1, sir. Depending on the finding on day 1, we'll decide whether to do on day 3 or day 7. So depending on those scans, follow-up will be done, sir. And day 28 scan will do, sir.
What are the things that you had to look for when you do it yourself?
Yes, sir.
Okay, so what are the things you will look for when you do a head ultrasound? If you want, this is all optional topics, huh? Okay. But if you're doing, then I am interested to know what all you want to look for.
So we'll look for any bleed in the brain.
No. I mean, you should have an orientation, no? Orientation of how you're going to put the probe and how you can you just describe?
Yes, sir. We'll see in 2 views, sir, coronal and sagittal.
Okay.
So in the coronal view, we'll see the in 5 views, sir. The frontal and at the level of the lateral ventricle and third ventricle, and in the occipital and posterior part, sir. In the sagittal, we use the mid sagittal and lateral.
Okay.
And parasagittal.
Okay.
So on both sides, we'll look, sir.
So how do you look for bleed?
So first in the caudothalamic groove, we'll first initially look at the caudothalamic groove, sir, because initial bleed will start there. And then we'll look for any accumulation in the ventricle and is there any extension to the parenchyma.
No, ventricle. Before it reaches the ventricle, where do you find actually? Where does the bleeding from the ventricle start from?
Caudothalamic grooves and germinal matrix.
Okay. So you start there, isn't it? And something hanging like a grapes or something, which if it extends, if it's irregular, you would call it as hemorrhage. If it's regular, then you would say it is normal. What is the structure? Since you're doing only, I'm asking. Otherwise, you can go to next. Choroid plexus. Okay, good. So now just classify the types based on your ultrasound types of IVH. Since you are at IVH, you only ask for IVH. You only ask for IVH by bringing in during this thing. So yes.
Grade 1, sir, small GMH occupying less than 10% of the ventricle, sir. Grade 2 from 10 to 50%, and grade 3 more than 50. And final one is the parenchymal extension.
Okay. Any other classification available?
Yes, sir. Based on CT scan, we have if there is no GMH with ventricular dilatation, without ventricular dilatation, and then parenchymal involvement, sir. 4 grades.
Okay, fine. Other than IVH, anything else you're worried about since the preterm in this baby?
Leukomalacia, sir. Periventricular leukomalacia.
Very good. How do you look for PVL?
So any cystic changes in the parasagittal region, and will regularly monitor.
Cystic changes do you find as a first finding? When do you see cystic?
Sir, hyperintensities during the initial stages.
Okay, or can I say, suppose I am doing an ultrasound on day 3 and I am finding some whitish area around the ventricles, excessively white. So what is my diagnosis?
Initial periventricular flare. If it is persistent for more than 7 days, then...
Okay, so you would like to follow this up, isn't it? Whether it is subsiding or not. You would not like to diagnose in the first scan, PVL, isn't it? Unless, of course, there is other factor. So you would like to, so these are babies, since there is no chorioamnitis, fine. If you have even asymptomatic chorioamnitis, you would like to look specifically the periventricular region in the day 7 scan, isn't it? Or day 7 to 14 scan, you would specifically like to look at, because baby may be otherwise okay, and then later on you will find problems, isn't it? Cysts and all come much later, isn't it?
Yes,
okay, let's get out of this imaging and go on further. So no, you still not answered my question. Anything else in the first 2 weeks? You told about feeding. Reaching full feeds. You told about respiratory support. Anything else?
Jaundice during the first.
Okay, fine. Anything was there? If you are there, you have to mention. It was there. Jaundice was there. And how did you treat?
Jaundice was there and baby received phototherapy.
Okay, what is this low bilirubin kernicterus?
Depending on the other conditions, even the low amounts of bilirubin can cross the brain and cause injury.
Which group of babies do you find this?
Mostly in difficult transition babies and extreme premature
Okay. Okay, fine.
baby
Let's
with
leave
sepsis and
Yes. Anything else? Any other intervention you should have done? Very important intervention.
hello sir.
Sir?
Yeah. Are you able to hear me? See me?
Yes,
Yes, sir. Again, video is lost.
I did not get your question, sir.
Sir, are you there?
Every time it's happening, I like to switch off and then switch on the video. Then it comes back. Now I am visible, no?
Yes, sir.
Okay, okay. Yeah.
Can you repeat the question, sir?
So any other intervention you would have done, you should have done. I am sure you would have done it. You do not mention, but you should mention in the first 2 weeks of life for this baby.
We'll start with the caffeine in this child, sir. We're on respiratory support.
Sorry?
And
Caffeine.
caffeine.
Okay, fine.
Caffeine.
Fine.
And developmental support
Why
in
do you want to give caffeine for this baby?
So, because CAP trial, it showed the long-term development in the caffeine group is good, sir.
You have to think beyond
And
CAP
also
trial.
it-
Anything else more than after CAP trial? Okay, fine. Anyway, let's go back to the question again. What is the intervention? You said something just now. That is what is developmentally supporting care. So something related to that. You want to say anything you would really want to do start right from beginning?
Yes, sir. And we'll dim lights and we'll reduce the noise level and we'll do the cluster care.
Much more. Come on. All those things later. First thing. Oh, of course, I'm not saying they are not important. You say, let's say you complete the list, then we'll discuss it. Yeah.
And main with the handling of the baby, cluster care and positioning of the baby.
Okay.
And for any medications, we should avoid the rapid infusions.
Yes. What should you do as soon as the baby is stable? I want it out of, I know you are aware of the answer. I want it out of your mouth.
Kangaroo mother care.
Why no KMC mentioned so far? When did you start KMC in this baby?
So as soon as baby is hemodynamically stable,
when did you
we'll
start
start the KMC.
in this baby? When did you start KMC?
So we started in this baby around 3 weeks, sir. Because baby had stomy course, baby was on ventilation for a while. So we did not get the chance to.
If baby was hemodynamically stable, would you have started early?
Yes, sir.
What do you mean by hemodynamic stability as far as starting KMC is concerned?
So there should not be any inotropic support for the baby, and baby should be on minimal respiratory support.
Baby should not be any respiratory support. You want to reframe your answer?
Minimal respiratory support.
Minimal respiratory. What do you mean by minimal respiratory support?
And like baby is not on any ventilatory support. Baby is on either
baby is not on
invasive
invasive ventilation, isn't it? Would you like to do when the baby is on non-invasive ventilator support?
Yes, sir.
What are the non-invasive ventilator modes you are aware of?
CPAP and HFNC, and even NIPPV. NIPPV.
Anything more? Of course, not practiced universally. Some centers do, and then evidence is just coming in only. What are the type, or rather, the question you can take it more as a theoretical question. What are the other two types of NIV you can probably mention?
NIPPV, BiPAP, CPAP, HFNC.
Okay.
And NAVA also we can. NAVA.
What is NAVA?
Neurally adjusted ventilator assist, sir. So
you have to say non-invasive NAVA. NAVA doesn't answer you. It's a NIV NAVA. Anything more?
NIV NAVA. Sir?
Nava is not freely available. Something else is more freely. I'm not saying very easily available, more freely available. Any other mode of respiratory support you are aware of? Non-invasive?
Nasal HFO. But
Yes. You heard of nasal HFO?
yes, sir. But I have not used.
You don't. You okay? Fine. I'm not asking that. It's a theoretical question. Fine. So, can you? In which all of my question is something else? In which all of these Navy modes can you use KMC? My question is on KMC.
So basically, it all depends on the nursing care, sir. If even
Good. You know how to go around the question. Yes, that's also important in exam. Yeah. It is nursing care has to be is very challenging when you do KMC in these babies, but then you can do in all these modes, isn't it? Including nasal HFO, you can do in all these modes if the nursing care is appropriate. So probably all modes, isn't it? KMC can be done. What are the advantages of doing KMC?
So the evidence says it will improve the exclusive mother milks at age of 40 weeks, and it also decreases the length of hospital stay and decreases the sepsis part, and it also increases the anthropometric wise weight of the child, length and head circumference of the child.
Okay.
And also helpful in neurodevelopment.
Anything more? Some new concept? New concept in KMC. Okay, I'll ask you a direct question. How does breastfeeding get turned into vaccination when you do KMC? How does breastfeeding get converted to a immunization also when you do KMC for the baby, immunization for the baby?
Yeah, microbiota development, sir.
Yeah. Do you want to talk about it, or we can go on to this?
So it will help in the development of the by the skin of the mother. It will transfer microbiota to the baby, so it will help in the immunity of the child.
Or is it the other way around?
Even in the breastfeed,
Or
centromammary axis.
Is it the other way around? Baby skin microbes get transferred to mother, and mother produce antibodies, and it get transferred to the baby through breast milk. Is it that way, or mother's microbiota get transferred both ways? But the immunization principle is probably this way. Breast milk is supposed to be protective. That way, it is the immunization because of various. This is one of the things. Anyway, this is one of the very small things. Fine. Any other advantages of KMC?
Early initiation
of breast milk, and we can
Okay.
family centered care we can do,
Okay,
sir.
so you
and
can. What is this family centered neonatal intensive care?
So in this care, where we can involve the parents into the care of the baby, so as early as possible, so that it will improve both family confidence, and it will also affect the improvement of the baby.
Okay.
For the better weight gain, and
Okay.
it improves the exclusive mother's milk.
Fine. Go ahead. You're tired? Should we stop or do we go on? Dr. Lakshmi,
No, sir, we continue.
how much time we have?
Half an hour, sir.
Half an
3:30, sir. We are
Okay.
not tired.
You can tell
Pradeep
me
is not tired.
whenever you're tired, we can stop.
Pradeep is energetic, sir.
We'll continue, sir.
Okay, fine. Go ahead.
Examination, have we done the examination because time is running out?
Yeah, that's what he's not taking to that. Yeah. Going on.
Okay.
So coming to the general examination, sir.
So what is the age of the baby right now?
72 days, sir.
74 days. What is the corrected age?
38 weeks, sir.
38 weeks. Okay, fine.
So currently, baby is in open care system under warmer with set temperature of 36.7 and baby's temperature of 36.5 with heater output requirement of 25 to 30%.
Okay.
and baby is sleeping comfortably.
Can we
The
zoom in on the
warmer.
baby?
Yes, sir. Yes, sir.
That's the maximum, is it?
Yeah, this is a
We can get further, sir.
Okay. As much as possible, if possible, only within the limitation. Don't go out of frame.
Okay, sir.
Okay, fine. Great. Yeah. Go ahead. Go ahead.
Sir, baby is sleeping comfortably, sir, with the extension at both the upper limbs, at the elbow and at the knee. And baby is under open care system under radiant warmer with the set temperature of 36.7 and baby temperature is 36.8
Okay.
with zero heater. And baby is having temperature probe attached to the right hypochondrium.
Okay.
And baby is also having saturation probe on the left attached to the monitor with the SpO2 showing 97 with alarm limits of 90 to 100 and heart rate of 152. And baby's respiratory rate is 40 per minute.
Is the baby on any respiratory support?
Just minimal low flow oxygen, sir.
Do you
Yes, no,
want?
sir.
And what is your saturation?
No, sir, not on support, sir. No support. No.
No support. I'm seeing a tube there,
No,
right?
sir.
What is that? Maybe I'm not able to hear. See.
Just attached, sir.
No, not on any support, no?
No, sir.
Okay, okay, fine.
So then, coming to the anthropometry, sir.
Okay.
The head circumference, I'm checking, sir. Head circumference of the baby is 29.5, sir.
Okay.
And length of the baby is 39 centimeters, sir. And weight of the baby today is 1.46.
Where do you place the baby in the chart as per this?
So baby is under less than third sentence.
Show the. You can share the screen.
Share.
Sir, we will share the screen, sir.
Yeah.
Yeah. Okay. Start. It is good. Show it. Can you see, sir?
Yeah, I'm not seeing the something else I'm seeing. Yeah.
This one, sir, anthropometry.
Oh, okay. Yeah. Okay. Show that growth chart again. Okay.
In the growth, sir. So
Talk
in this
about-
child now corrected baby is 38 weeks, sir.
Okay.
So on the growth plot, all parameters like length, head circumference, and weight of the child is less than third centile, sir.
What is going to be the implication of this?
So this will indicate the extra-uterine growth restriction, sir, and will affects on the long-term neurodevelopment, sir.
Okay. So how do you prevent that? Very difficult question.
Yes, sir. In initial days to prevent extra-uterine growth restriction, we need to start the early aggressive nutrition with starting of feed on day 1 of life with appropriate increment in the feed day by day with adding of appropriate fortification as needed and treating the underlying comorbid conditions also.
Any other chart you would probably want to, if you don't want to use this Fendons, any other chart you have at this point of time to use?
Intergrowth and Ehrenkrantz.
Ehrenkrantz. Okay. How will this baby fare on Ehrenkrantz chart?
I have not plotted, sir, but it has the adjusted for the morbidity, so we can plot and see in that.
What is the
sir.
problem with Ehrenkrantz?
It has only no centile, sir. It has only single trajectory and is based on the weight of the babies.
What is the population that is assessed in Ehrenkrantz? Based on which the plot is made? Chart is made based on some other group of populations, isn't it?
Yes, sir.
Even Fenton's is like that, and it's slightly better only. So these are probably not appropriate charts for us to assess the EUGR per se. Now, what are you going to do about
Yes,
it? Now you have baby is a stable baby off respiratory support, and you find that baby is faltering. Baby is not going away from the growth chart. Now, what are you going to do about this?
Yes, as we can see on the chart, sir, baby was right now since last 2 weeks, baby's weight gain is good, sir. So we will supplement with the adequate calories and protein. As of now, baby is getting 140 calories and 3.8 protein, sir. So
any role for any micronutrient at this point?
Sir, because currently baby is on formula feed, sir. So baby is getting adequate micronutrients.
Okay.
And baby is also on multivitamin supplementation.
Okay, suppose baby was on, say, only mother's own milk. What all would you like to supplement for the feed of this baby?
We'll start with the fortification, sir. With human milk fortifier or bovine milk fortifier.
Okay.
And we also add the multivitamins to the baby.
Better? Human milk for human HMF or bovine HMF?
Sir, as such, there are no evidence as of now, sir.
Very good. Okay, fine.
Both the fortifier shows the similar efficacy.
Okay, fine. We don't have evidence to say which is better. Fine. Go ahead.
And then we'll add the we'll calculate the nutrition of the child every week.
Okay.
And which component baby is on the lower side will supplement with that, sir.
Is there any scope for increase in the calorie protein intake of this baby?
Sir, we can add MCT if you want to increase calories in this child.
Okay. Comment on that. Comment on the statement you just now made. Am I audible? Am I audible?
Yeah, you are audible.
But I lost whatever was said just now. Dr. Pradeep? Are you able to hear me? Dr. Pradeep, are you able to hear me?
Yes, sir. Am I audible, sir?
I lost you totally. I'm not able, last 5 minutes, I'm not able to hear anything what you said.
Do you hear us, sir, now?
Yes, sir, no?
Yes, now I can hear you.
Yes, sir.
I'm sorry, can you repeat whatever you said? Because I did not hear anything, whatever you said.
So to improve the calorie in this child, we can add the MCT oil, sir.
Okay, so that is where, why do you want to add MCT oil?
So we are giving adequate protein,
Okay.
and we documented the normal bun levels also, blood urea nitrogen. So as
Okay.
we cannot measure the lean body mass, we can give the calorie dense feeds.
No. Your
And we can see-
what is your protein intake?
3.8, sir.
3.8. Is there any scope for your increasing it further?
Yes, sir. Yes, sir. We can increase. We can increase, sir. We can increase up to 4.5. Hello.
Hello, sir. Disconnect. Screen share చేసేవారు. Sir, can you hear us? Disconnected. Sir, connection. Ma'am, can you hear us, ma'am? Lakshmi, ma'am?
We can hear you. We can hear you.
Okay.
We can hear you. Continue. Someone continue from there.
Yeah. Nalli sir, तुम continue करो.
Pradeep, did you finish your examination, all three parameters of anthropometry and its interpretation?
Yes, sir.
Because by classifying UGR by just weight centile, do you think you can use as a surrogate for the overall outcome at 2 years? Such a preterm babies only just by saying your weight is low or UGR. Is it a good surrogate marker for a long-term outcome?
Head circumference also we need to see, sir. Head circumference and is also on the lower centile, sir.
Okay, then you present, just go on examining and tell what are the features are there now and what are the things we can optimize there.
8 minutes, sir. इसको थोड़ा drop करो saturation. You can do. Yes.
Then head to toe examination. Head circumference, as I mentioned, is 29.5, and there is no sutural overriding. AF is 2 into 1 centimeter, and posterior quadrangle is open. And there is pallor is there, and no stress, and baby is having mild pedal edema with groin edema, and buccal pad of fat is full, and muscle mass is also normal.
So baby,
And without circumference,
I want to interrupt here. Baby is still now pale looking. Baby's pallor is there.
yes, sir.
So baby-
Pallor is there, sir.
Did the baby had some history of any transfusions or any transfusion recently or past history?
Yes, sir. Baby had transfusions of 4 during the NHC course, sir.
So do you think that the outcome, the growth outcome, what we are not optimally achieving after the nutrition of good nutrition, protein and calorie, is it related some way
Yes,
to
yes, sir.
time of anemia?
Yes, sir. We also need to consider the other comorbid conditions which can increase the demand of the child. The associated, like under the
So anything is there?
as baby had
Anything is there in the baby specific morbidity which can influence the growth?
and chronic lung disease,
Okay.
and this baby also had anemia.
Okay.
And any dyselectrolytemia also we should consider correcting, sir.
Okay.
And
Any thyroid issue, anything sorted out?
yes, sir. Thyroids are normal, sir, in this child.
So can you optimize the care better so that the multiple transfusions and anemia, we won't face such a growing baby? What you can do from beginning, the care regarding?
Yes, sir. For care regarding as a primary prevention, we can optimize the maternal nutrition, and in the delivery room we can do the delayed cord clamping. And during the initial days, we can decreases the excessive blood collection, and so that we can do the blood during day one samples from the cord blade. And by doing the point of care devices, we can collect the capillary blood, and we can avoid the excessive phlebotomy in this child. And by early initiation of the feeds and early supplementation with the iron supplementation and early fortification. And we can also, by using the protocolized transfusion, we can decreases the number of transfusion baby required, sir.
Okay. So till now, just address the anemia and how to prevent. So Dr. Bishay Manoj sir can take lead now. Actually, I was asking this baby with a repeated history of transfusion and anemia, so that may be a factor of growth failure in this baby. How to optimize the care? I was asking. Please lead.
Yeah. Okay. I'm sorry, I got automatically logged out. And then, am I visible and audible now?
Yeah, perfectly.
Yes, sir.
Okay. So, what are the implications? Can you just summarize what you said now? What are the implications of anemia in the growth of this baby?
Yes, sir. Because anemia can cause the increased demand in the child. So, if we are not supporting with the adequate calories, so it can cause the growth faltering.
But you were talking about suppose you have excess you want to increase. We are talking about that is clarified already. Should we discuss MCTOL now, or it is already discussed, completed?
No, sir.
No, sir. Not discussed.
Sir. Okay. So, what is the problem in giving MCTOL to this baby? You wanted to give MCTOL, no?
So it won't add to the extra protein, sir. It will only add the energy. So it will increases the fat mass.
Okay, that is exactly what we said initially. We want to, the outcome is based on the lean body mass, isn't it? You need to only make sure that protein what we give is not being utilized to produce calories. That is all. Otherwise, you should give maximum protein that is tolerated by the baby, isn't it? So if you are going to give MCT oil, that is, baby is going to put on weight and become very chubby. But the problem is, you are not going to get any benefit out of it. The outcomes are not going to be. So you don't want to use MCT oil until you have a particular scenario where protein is adequate and calories deficient, which is very, very unlikely if you use. In your scenario also, it is proportionately okay. What you mentioned are proportionately okay. If you try to increase the calories now with such measures, you are not going to improve the outcome. So I would not use MCT oil in this baby. Agree or not?
Yes, sir.
Okay. Now, you are going to now assess what is your plan now? What plan of management hereafter? We are in the last 10-15 minutes.
Optimize the growth of this child, sir. So
how are you going to optimize the growth? Basic points.
So we will consider the other comorbid condition in this child. So as baby is having baby looking pallor, so we will optimize the hemoglobin levels, and we'll also look at the metabolic parameters of the child. There are any dyselectrolytemia, we'll correct that.
What all screening you want to do before you do all this for this baby?
So for preterm babies, usually by day 21 we'll do the ROP screening.
Okay.
And we'll also do the regular neurosonogram, and as baby cross 34 weeks, we'll do the hearing test.
Okay. Anything else?
And thyroid also will thyroid level will check.
Okay.
And regular electrolytes and calcium, phosphorus.
Would you like to look at the sodium level of the baby or something if the baby is not growing?
Yes, sir. Electrolytes, yes, sir. If there is any hyponatremia, we'll correct that, sir.
Okay. So now, can you show me how you are going to assess? So you are going to add what is the neurodevelopmental assessment plan? We are only 10 minutes, so we need to go to the important topics. So
at the time of the discharge, as a baseline, we should look at the activity of the child and neuromuscular development and maturity.
How? Any scoring system you are aware of?
Yes, sir. Hammersmith infantile neonatal examination, sir. Heinz score.
Okay. Any short version of that?
Even we'll do the Hamilton angles.
Can you just show Hamilton angle? Demonstrate how you do Hamilton angle in the baby.
Yes, sir. In the Hamilton angle, for the upper limbs, we'll do the scarf sign. So in the scarf sign, so whatever the hand we are checking, we should remove any probe attached to that hand. We should make sure the head of the baby is in the midline, and by holding the wrist, we will move the hand of the child to the opposite shoulder. So based on the crossing of the leg, so this baby is just reaching the midline, sir.
Okay. Now, how? Yeah, continue. You finish your assessment of 80 angle. Then we'll discuss. Yeah.
Then we'll also look at the popliteal angles, sir, and the adductor angles. So for the popliteal angles, we should remove the diaper, and then after stabilizing the opposite hip and by flexing the hip to the abdomen, we need to extend the limb, and we need to see the angle at the knee joint.
Okay. Yeah, that's it.
And then the adductor angle. So for that, we need to place both the hands under both the legs, and we need to stabilize the hip. And by using the thumb and index finger, we should abduct at the hip.
I'm not able to see whether you're doing it correctly or not. Hopefully, anyway, you are aware of how you. It's very difficult to do the examination like this, but you are aware of how to do it.
Yes, sir.
Just tell me what all you do. Just screening procedure. What all you do say, because there's no meaning in saying like this when I am not able to see what you're doing. So just tell me what all you do in this baby. What all the screening, the basics.
So we'll do the basic neurological examination at discharge, sir, by using Hein or Hamilton angle. And then we'll screen for the retinopathy of prematurity, and we'll follow it up, and we'll screen for the hearing.
So you will do ROP only twice, one at 21 weeks of life, and
no, not twice, sir. We'll follow based on the the mature retina. Yes, sir.
Okay, fine. Go ahead.
And hearing will do, sir.
Before that, I just there's an interesting question. I just saw the chat box. Iron the baby is receiving is more than 4 milligram per kg now, and previously baby received 4 transfusions. Comment on it. Very good observation. I did not hear this part about the iron supplementation. What is your concept about iron supplementation in this baby?
So baby is receiving adequate iron supplementation, sir.
No, adequate. What do you mean by adequate? How many transfusions?
So as a recommendation, it should be like 2 to 3 mg per kg.
If you want to treat, how high can you go on iron supplementation? 5 to 6
mg per kg.
Okay. But in a baby, the question is, in a baby who has received transfusion, this baby received 4 blood transfusions?
Yes, sir.
Right?
Yes, sir.
In such a case, then would you like to do anything before you start the baby on iron?
Yes, sir. Erythropoietin, we can try, sir, during initial.
No. I'm not talking what you want to do. Anything you want to check?
Ferritin levels.
So have you checked ferritin levels?
No, sir.
Okay, fine. So probably you would want to check your ferritin levels. If the iron stores are enough, then probably another thing what you just mentioned is being tried. Is that the standard of care, erythropoietin?
No, sir.
No, but it is being used, isn't it?
Yes, sir.
Okay. Do you use erythropoietin?
No, sir.
Okay, you don't use. Okay, fine. So do you want to check ferritin level in this baby?
Yes, sir.
How severe is the anemia here?
Now currently baby is 7.2 hemoglobin, sir.
What is the peripheral smear picture showing?
It's a microcytic hypochromic only, sir.
Okay. So probably it may be a good idea to check your ferritin level before you decide on the dose of iron that you give, isn't it?
Yes, sir.
Okay, now let's go back to your neurodevelopmental assessment. So, are you worried about, suppose I am the parent, now you're going to discharge the baby. Just counsel me. How are you going to counsel me regarding the growth and neurodevelopment?
Yes, sir. As baby is extreme premature, so baby is currently growth faltering, but so compared to the last 2 to 3 weeks, baby is currently growing well. So before discharge, we'll make sure the growth of the baby is adequate.
How do you make sure that baby is growing well? Any objective criteria you can tell me, doctor? I am the mother of the baby.
So weight of the child we'll check.
How much is the baby gaining, doctor?
Yeah, now around 15 to 20 grams per kg per day is the ideal weight gain.
Per kg per day is gaining.
Yes, sir.
Okay. What was the birth weight?
780 grams, sir.
What is the present weight?
1.45.
Okay, fine. Go ahead.
And then we'll regularly monitor the weight of the child.
Okay.
And we'll advise the mother.
How many neuroimaging scans have you done for the baby so far?
This three, sir.
3.
Yes, sir.
And all are normal.
All are normal. All are normal. Sir.
Okay. Any further plans for neuroimaging in this baby?
So depending on clinical assessment, sir, neurological assessment, we'll plan if required, sir. As of now, there is no routine plan of doing any.
What is your assessment plan, neurodevelopmental assessment plan in the coming days? How free?
Yes, sir. That we'll do, sir. After discharging, initial for few days, we'll for the growth monitoring, we'll monitor every 2 to.
Do you tell mother, I am the mother, anything to be done to the baby, some exercise or something you want to tell me to do when you discharge?
Sir, physiotherapy we'll do, sir, and we'll ask the mother to do the KNC at home.
Physiotherapy, or you want to be more specific? That's a very crude term for the baby.
Occupational.
Now, what do you want to do? What do you want me to do? I'm the mother.
So KMC we can ask the mother to do, sir, for better growth and development. And developmental supportive care we can teach the mother.
Yeah. What is early stimulation?
Yes, sir. We should regularly follow up the baby for the neurological assessment, and depending on the assessment findings, we'll do the appropriate stimulation for the baby, like vision and hearing and muscle tone strengthening.
Okay. Okay, go ahead. We almost time, so just go ahead.
Then follow up wise, we'll assess the nutritional status and growth of the child, and regular eye monitoring and hearing if we done, and at the 3 months of age we'll do the BERA for the baby, and at regular intervals like we usually follow at 2 months, 4 months, 6 months, 9 months and 12 months, and till 2 years of age neurodevelopmental assessment and regular vaccination for the baby.
What about the feeding practice? How should I be feeding the baby? I am the mother.
Sir, currently as baby weight is 1.45, we ask the mother to give the Pallada feeds, and meanwhile mother can try giving the non-nutritive sucking so that it will improve the function of the baby, and we also give the oromotor stimulation for the baby.
When do you start non-nutritional sucking?
Usually around 30 to 32 weeks will start, sir.
Much early, isn't it? Already that would have been done. Right now, what should be the feeding method? How should you be feeding?
So as baby weight is less at the point of time 1.45.
Okay.
We'll continue with the Pallada feed, sir. So
Okay.
once the baby gain.
When do you put the baby to breast for breastfeeding?
So usually depending on the baby's condition also and baby's reflexes, But usually after
In this
attainment
baby,
of
you
2
said
kg,
reflex are all normal, isn't it? So
yes,
38
sir.
weeks baby now. 38 weeks, isn't it?
Yes, sir. 38 weeks.
Ah. So do you want to breastfeed the baby?
Now, because how much baby take we don't know, sir. So initially measured feeds will advise, sir. Once the baby's growth at home is adequate, because some babies usually after going home they will come with the loss of weight, and we don't know what amount of breast milk baby takes. So we make sure that initial 1 to 2 weeks of adequate weight gain on measured feeds, then we can.
What is the problem if you just say only give Palada feeds? What is the problem in the problem you want to say, or I'll give you a clue?
Some.
In the, I mean, in the what is going to happen to your breast milk, mother's breast milk?
Yeah, it will decrease, sir.
So do you want to try breastfeeding?
Yes, sir, 1 or 2 times we can.
So how many times do you do NNS per day? How many times baby is
Yes.
getting non-nutritional sucking now?
Usually in ICUs around 4 to 5 times, sir. But at home, as much as baby can take, that we can try.
Okay, how do you do non-nutritional sucking?
So after complete expression of the breast milk, we'll offer the child to suck at the breast.
Okay. Then what do you do with the milk that you expressed?
So we usually give it to the baby, sir.
What are the
So
advantages
whatever
of
required
giving?
amount.
What are the advantages of expressing milk first and then putting the baby to breast and then giving the expressed milk by Palada to the baby? Any advantages of this concept?
So because it will also give the hind milk for the baby for the required calories and fat content.
What is the difference in the between the fore milk and the hind milk? Going back to basics
So
again.
fore milk usually it will contain it will give the baby the satiety, sir, but whatever the calories and fat requirement usually will get from the hind milk.
Okay. And how, I mean, how are you going to schedule this feeding for the baby? I mean, at the time of discharge, how many times?
So every 3 hourly we'll give feed in this child, sir.
Okay.
And we'll ask the mother to express the milk.
Okay. So when does the concept of demand feeding comes in this baby? What is demand feeding?
So whenever on top of the whatever feed we are giving, if baby is hungry and crying a lot, that time we can offer the feed for the baby.
Okay, fine. So like in this baby, when do you do demand feeding?
First we'll make sure the adequate growth, sir. Then for adequate growth, once the baby is more like persistent growth over next 2 weeks, then we can try for the demand feed.
Okay. I think Dr. Lakshmi, what do you do?
I think we have covered most of the other aspects. Anything left out?
Anything, there are a lot. It depends on the time actually and the.
No, time we are over almost. Yeah, it will close.
Okay. Anything
2 to
else
4.
to be? Anything you want to ask me?
No, any comments to the
Pradeep.
participants?
Yeah. Okay. Comments. Let me just.
You want to ask, sir?
So regarding the same, sir, regarding iron.
Regarding early intervention, early stimulation, we just touched upon. You did not answer that properly. Somebody has written. Then I don't see any other comments in the chat box. I'm not sure whether I'm not used to this software, so I'm not very sure whether I'm seeing the correct place or not.
Nalini sir, are you there?
Anyway, the Pradeep, you have done very well. Okay, it is just how do you assess yourself?
Medium to good, sir.
Let me see your face. Take off from the baby. Okay, focus the camera. Yeah. Okay. Assess yourself now. How do you can put the mask? I just joking only. So like in the hospital now. So how do you assess yourself? How have you done? Like
Medium to good, sir.
okay. Okay, fine. So the examination is an art. It is the way you take the examiner. If you are very thorough with some topic, you can take the examiner. But then problem I found was you are not, and you're just giving when you're talking about, because at this level when you're talking about neonatology, you should be talking with evidence. No, you are just saying statements not being backed up with some study or something. And so probably that is one area where you can probably improve upon whenever you say interventions, because there are a lot of things in neonatology that are still not black and white. They are all shades of gray. Neonatology is more of gray than black and white. So until you the way you answer is okay for MD, because there it is like, or maybe I would say even now, even not even MD, MBBS, because everything is black and white. It's not like that anymore. So when you say any intervention, you have to know the pros and cons and studies and all that. And there is a new concept of precision medicine also coming. What is precision? Last question. What is precision medicine? Okay. Precision med. You are able to hear me, no? My video again. Are you able to hear me? Yes, sir. Okay. See, the concept of treatment itself is changing. Precision medicine did not come in neonatology first. It has come in other branches, and it is now coming to neonatal medicine, especially in preterm care. That's why I asked. Because the concept is the same disease can be treated in different ways and responds differently in different patients. The same treatment may not work, isn't it? So you need to individualize treatment. The concept of precision medicine came in oncology first, and now it is there everywhere. So in preterm care also, there is a lot of role for individualization of care. So that is why you should be talking about evidence most of the time. You should not be just jumping at this is got it now.
Yeah.
Yes.
Okay. I think we can wind up from my side. Anything more to be done, Dr. Lakshmi?
Okay.
So well
Anything
done,
else?
Pradeep. Pradeep, you have done very well. Good.
Okay, sir. Thank you, sir.
Any
Thank you.
comments?
Thanks, Pradeep. Thank you, Rainbow team, and thank you, Manoj.
Yeah. Thank you. Thank you so much.
Thank you, ma'am. Anything in the chat box, ma'am?
I didn't get it.